नमस्कार। आज का हमारा टॉपिक है एंटीपार्टम हेमरेज। इसमें हम डिस्कस करेंगे क्यों एंटीपार्टम हेमरेज होते हैं। एंटीपार्टम हेमरेज APH is defined as bleeding from the genital tract after fetal viability. Fetal viability. Bleeding from genital tract after fetal viability and before delivery. In the past, viability was considered to be from 28th week onwards, but due to improvement in neonatal survival, changes are occurring. The cut-off point for fetal viability is now considered as 22 weeks by WHO. In United Kingdom, 24 weeks is taken as the cutoff for fetal viability by Royal College of Obs and Gynecologists. Antepartum hemorrhage complicates 2 to 5% of all pregnancies. And has a high maternal and fetal mortality and morbidity. Management involves a disciplinary team comprising a senior obstetrician, an expert anesthetist, a neonatologist, and a good blood bank backup. Causes of APH placenta previa. Here we can see placenta previa, abruptio placenta. Here we can see abruptio placenta, the cases of abruptio placenta. Local causes like polyps, cervical cancers, varicose veins, and local trauma can also occur antepartum hemorrhage. Circumvallate placenta. Here we can see normal placenta. This is circummarginate placenta, and here we can see the cases of circumvallate placenta. Here we can see the thickened grayish white ring on the fetal surface created by a double fold of amnion and chorion with degenerated decidua and fibrin in between. Next cause can be vasa previa. In this diagram we can see vasa previa with velamentous insertion of the cord. Type 2 vasa previa with vessel running between the main placenta and succenturiate lobe. This is the case of vasa previa. This is another case of vasa previa. Here we can see in this diagram the language is probably Russian, but we can see here the cases of vasa previa. Here we can again see the cases of vasa previa with rupture of umbilical vessels that leads to bleeding, antepartum hemorrhage. Placenta previa. Placenta previa is defined as the placenta located partially or completely in the lower uterine segment. The bleeding is called inevitable or unavoidable hemorrhage. As dilation of the internal os inevitably results in hemorrhage. Classification. Type 1. Low-lying placenta or lateral placenta previa. The placenta edge does not reach the internal os. Type 1. Low-lying placenta or lateral placenta. Lateral placenta previa. The placenta is does not reach the internal os but is in close proximity to it. Type 2. Marginal placenta previa. The placental edge reaches the margin of internal os but does not cover it. Type 3. Partial or incomplete. Here we can see in between the two there is a type 2 which is marginal, slightly more towards the internal os, and partial placenta previa which is type 3 according to me. Here we can see this is type 1. This is type 1 and this is type 3. In between one more thing is type 2 and this is type 4. To see, then let us see type 3. Partial or incomplete central placenta previa. The placenta cover the internal os partially, that is, it covers the internal os when closed but only partially when os is dilated. Type 4. Total, central or complete placenta previa. The placenta cover the internal os completely, that is, even when dilated. The first two are called minor degree. The first two are called minor degree. And the last two are called major degree of placenta previa. The placenta can be anterior or posterior in the minor degree. Anterior or posterior in the minor degree. Type 2 posterior placenta is also called the dangerous type. Type 2 posterior means little more towards the internal os, the type 2, and situated in the posterior part, in the posterior aspect, is also called dangerous type, as it is likely to be compressed between the fetal head and the sacral promontory in labor, producing cord compression and fetal distress. Type 2 posterior placenta is also called the dangerous type, as it is likely to be compressed between the fetal head and the sacral promontory in labor, producing cord compression and fetal distress. This can cause fetal asphyxia and even death. This traditional classification of placenta previa refer to location of placenta in relation to a dilated cervix. This traditional classification of placenta previa, which we are studied here, refers to location of placenta in relation to dilated cervix. For example, a placenta that appears to be complete before cervical dilation may become partial at 3 centimeter dilation and vice versa. Means here we classified in relation to dilated cervix. Distal palpation to ascertain the relationship of placenta with cervical os. Distal palpation to ascertain the relationship of distal palpation by digits. Digital palpation to ascertain the relationship of placenta with cervical os is not an opinion as it can lead to torrential hemorrhage. This is where ultrasound has helped us. With the advent of transvaginal scanning, the cervix can be imaged even when not dilated. With the advent of transvaginal scanning, the cervix can be imagined even when not dilated, and the os is seen as a point, not a dilated cervix. Hence, it is the distance between the placental ridge and the internal os as measured on ultrasound that is more important. This will be described further. Why does bleeding occur in placenta previa? Incidence. The overall incidence is about 1 in 300 deliveries. Etiology. The exact cause of placenta previa is not known. It has been suggested that damage to endometrium or myometrium can predispose to a low implantation and subsequent development of placenta previa. Such damage can be either due to previous uterine surgery or infection. Prior surgery on the uterus, especially caesarean section, increases the incidence of placenta previa 2 to 3-fold. The combination of a prior caesarean section with an anterior placenta previa is particularly dangerous as it increases the chances of morbidity. Adherent placenta, such as placenta accreta, encreta, and percreta. The combination of a prior caesarean section with anterior placenta previa is particularly dangerous as it increases the chances of morbidly adherent placenta such as placenta accreta, encreta, or percreta. In previous caesarean section, due to defective vascularization, the decidua in the lower segment may be poorly developed, and this lead to an adherent placenta. Here we can see the normal decidua placenta attached to the uterus until labor, when it separates with the help of contraction. Encreta, more deeply attached. Placenta is more deeply attached to the muscle wall of uterus than accreta. Means here we can see that decidua, after decidua we can see the cases of accreta. The placenta is too deeply attached to the uterus. Here we can see, and here one layer of stratum basilis of endometrium is also present. Here we can see the in accreta the placenta is too deeply attached to the uterus. In increta it is more deeply attached to the muscle wall of the uterus than accreta, and in percreta see that the placenta grows through the uterus and can extend to the nearby organ. Here if any organ is present, then it also surround it. See the cases of normal, eccrita, incrita, and percrita. In previous caesarean section, due to defective vascularization, the decidua in the lower segment may be poorly developed, and this lead to an adherent placenta. Other surgical procedures like myomectomy and dilatation and curettage can also predispose. Here we can see the dilatation and curettage process. Dilatation and curettage. We can use the different instrument and do dilatation, dilatation and curettage. Other causes of placenta previa is infection or chorioamnionitis. It can be other um, associated with other problems like previous placenta previa, advanced maternal age, multiparity, multiple pregnancy, malpresentation, smoking, prior caesarean section is the main cause of placental previa and adherent placenta. The incidence is 4 times greater in patient with a previous caesarean. Clinical features. Here we can see the risk factor: increased maternal age and parity, multi-fetal gestation, prior caesarean delivery, prior uterine incision, cigarette smoking. Carbon monoxide causes hypoxemia, and this will leads to placental hypertrophy. The main symptoms of placenta previa is painless hemorrhage. The classical presentation is painless antepartum hemorrhage. The typical history is of the woman waking up lying in a pool of blood. The initial bleeding is usually not severe, but it stops only to recur at a later date. In fact, painless and recurrent bouts of bleeding are characteristics. In this table, we can summarize all the events once more, and here we can see that pregnancy, first sign after woman misses her period is more often urination, belly biggers, belly gets bigger, breast also gets bigger, pregnancy marks, dark areas on face, breast and belly during fifth month. Sorry, it is the first sign is second morning sickness with feeling of nausea and vomiting. Here is the uh, let's again summarize. Pregnancy is first sign of pregnancy is woman misses her period, and second sign is morning sickness with feeling of nausea or vomiting, worse in the second and third month of pregnancy. Here, sign afterwards, more often urination, belly gets bigger, breast also get bigger, pregnancy marks, dark areas on face, breast and belly. During fifth month or so, child started to move in the womb. If there is ectopic pregnancy, then the symptom and treatment: tender lump as baby forms outside womb. Tender lump as baby forms outside womb, abnormal period bleeding, pregnancy sign, surgery. At hospital is the treatment. Danger associated with pregnancy, bleeding during first 6 months of pregnancy. If it is during first 6 months of pregnancy, then it can be due to uh, miscarriage, losing the baby. She should lie quietly and be hospitalized soon. It is the plan of treatment and well-being for well-being of mother. If there is bleeding after 6 months of pregnancy, then possible cause and treatment will be, the possible cause is placenta previa, birth opening. Placenta previa means birth opening gets blocked by placenta, means placenta previa can be um, the reason bleeding after 6 months of pregnancy, and woman may bleed to death. So we need to need uh, immediate hospitalization for of the patient. In case of severe anemia, symptom is weak, tired, and pale, or transparent skin, pale inside of eyelids, white finger nails, pale gums. Treatment is must to prevent death due to blood loss at childbirth. For severe anemia, good diet and childbirth should be at hospital as extra blood may be needed. If there is toxemia or poisoning of pregnancy, then prevention can be eat nutritious and protein rich food and use very little salt. Symptoms during the last 3 months of pregnancy: swelling of feet, hands, face, headache, dizziness, sometimes blurred vision, sudden weight gain, high blood pressure, lots of protein in urine. Only feet swelling is not so serious. Then it is the case of pleasant. It is the case of pre-eclampsia and eclampsia. The treatment: consult gynecologist and obstetrician. Stay quiet in bed and avoid salt and salty food. Signs: sign: painless bleeding, bleeding severe, less or slight, where in abruptio placenta, severe constant pain after with the loss of FHR, bleeding severe, less or absent, it can be concealed. Third, shock and anemia if the bleeding has been slight, shock and anemia if bleeding has been severe. Hypertension and proteinuria is common in abruptio placenta, no hypertension and proteinuria. Uterus hard and tender, whereas in placenta previa the uterus is soft and non-tender. Fifth, sixth, fetal parts difficult to feel, presenting part is high or mal presentation can be seen. Signs: pallor, if present, will be proportionate to the amount of bleeding. Size of the uterus correspond to the period of amenorrhea. Uterus is soft and non-tender. Placenta previa, uterus is soft and non-tender. Mal presentation is common, and if it is cephalic presentation, the head is usually floating. If fetal part are easily palpable and presenting part is floating, it is more likely to be a posterior placenta. In an anterior placenta, the fetal parts may not be easily palpable. If the fetal part is easily palpable and the presenting part is floating, it is most likely to be a posterior placenta. In anterior placenta, the fetal part may not be easily palpable. Fetal heart sound will be usually heard. Slowing of fetal heart rate on pressing of head down into the pelvis and prompt recovery on release of pressure is termed a stall-worthy sign and is suggestive of posterior placenta previa. Vaginal examination should not be done in suspected placenta previa. Diagnosis. Ultrasound. Ultrasound is very useful to diagnose placenta previa. And today, most cases are diagnosed on a routine ultrasound. Ultrasound is extensively used in antepartum hemorrhage to locate the placenta and to assess fetal well being. It may sometimes help in diagnosing abruptio placenta by the presence of retroplacental clots. It may sometimes help in diagnosing abruptio placenta by the presence of retroplacental clots, but the main role is to rule out a placenta previa. Today, transvaginal ultrasound is being used increasingly in diagnosing placenta previa. It is safe and gives much more accuracy than a transabdominal scan. In placental localization, especially in posterior placentation and obese patients, in case of marginal and low lying placenta, also it is preferable to do a transvaginal scan to confirm the diagnosis and measure the exact distance between the internal os and placental edge. Margination. If the earlier scan showed a placenta completely over the internal os, it is most likely to persist in the latter scan. If the 80 to 20 weeks scan revealed a low-lying placenta or a marginal placenta previa, placenta localization is best repeated about 32 weeks. In cases of marginal and low-lying placenta, it is preferable to do transvaginal scan to confirm the diagnosis and measure the exact distance between internal os and placental edge. Migration. If the earlier scan showed a placenta completely over the internal os, it is most likely to persist in the latter scan. If the 18 to 20 weeks scan revealed a low-lying placenta or marginal placenta previa, if the 18 to 20 weeks scan revealed a low-lying and marginal placenta or low-lying placenta or marginal placenta previa, the placental localization is best revealed around 32 weeks. By this time, in many cases, placental migration would have occurred. The term migration is a misnomer and is due to differential growth of upper and lower uterine segment as pregnancy proceeds. The lower segment is 0.5 cm at 20 weeks and 5 cm at term. This is less likely to occur in the posterior placenta or if there has been a prior caesarean section. This is less likely to occur in the posterior placenta or if there has been a prior caesarean section. Ultrasound is invaluable in the accurate diagnosis of placenta previa. A definitive diagnosis of placenta previa can be confirmed by 32 weeks. Adherent placenta. When the combination of the prior caesarean section and the and an anterior placenta previa is seen, an adherent placenta should be anticipated. Sometimes it may be suspected on ultrasound by the absence of usual subplacental sonolucent zone. Doppler is helpful to diagnose an adherent placenta. MRI may also be helpful in such cases. Uh, Ultrasound findings and management. When the placenta covers the internal os, or if the placental edge is within 1 centimeter of the os, caesarean section has to be done. Cases where the placenta edge is more than 2 cm from the os are considered not to have a placenta previa. Cases where the placental edge is more than 2 cm from the os are considered not to have a placenta previa. In those which have an edge between 1 to 2 centimeter of the internal os that remains in the gray zone. In such cases, there may be place for double setup, explained next, and some patient may be given an attempt at vaginal delivery. Placental edge more than 2 cm from the internal os can be considered normal. Placental is within 1 centimeter of the os should be delivered caesarean. Here 1 centimeter. And between 1 to 2 centimeter is a gray zone and best individualized differential diagnosis. The main differential diagnosis is, of course, abruption and other causes of antepartum hemorrhage listed earlier, and we will discuss the differentiation from abruptio placenta is necessary. अब्रप्शिय प्लेसेंटा में पेन होता है जबकि प्लेसेंटा प्रीविया में नहीं होता. यहाँ पर क्या रिस्क फैक्टर होते हैं? प्रीवियस एब्रप्शन, हाइपरटेंशन, ट्रॉमा, कोकाइन अब्यूज. वाइल इन प्लेसेंटा प्रीविया there is previous previa, multiparity, structural abnormality, for example fibroids, advanced maternal age is the complications. The reduction in maternal mortality from placenta previa has been tremendous due to the increased use of caesarean section and blood transfusion. Current figure is less than 0.1%. The main cause of death is hemorrhage. Recently, the increasing incidence of morbidity adherent placenta following a prior caesarean section is becoming a cause for concern. Maternal shock due to antepartum hemorrhage, increased chances of caesarean section, postpartum hemorrhage, morbidly adherent placenta, placenta accreta, increta, and percreta. Perinatal, prematurity, hypoxia due to placental separation. The perinatal mortality has declined ever since the expectant line of management was introduced by McAfee and Johnson. The main cause of perinatal loss is still prematurity. Management. Initial management in all APH cases. As a general rule, all patients presenting with antepartum hemorrhage should be investigated and managed as outlined. A proper history is taken and clinical examination is performed to arrive at diagnosis and rule out abruption. A minimum of true intravenous line with a 14 or 16 gauge cannula are set up and rapid infusion of crystalloid like normal saline or colloid started until blood transfusion can be given. Blood is taken for hemoglobin, packed cell volume, grouping, and cross matching. If abruption is suspected, a coagulation profile is done, which is described under abruption. Blood transfusion should be started as soon as possible if necessary. Ultrasound is done to localize the placenta and confirm fetal well being. A vaginal examination is never done in placenta previa except in the rare circumstances outlined below. A speculum examination is necessary to rule out local cervical and vaginal cause for the bleeding. It is usually performed after the bleeding has ceased. If placenta previa is suspected, a sample of the blood is taken by speculum examination to test for fetal hemoglobin and thereby confirm the diagnosis. Expectant line of management in placenta previa. This regimen was advocated by McAfee and Johnson in 1945 and is based upon the fact that in placenta previa the bleeding usually occurs when the fetus is premature and stop on its own to recur at a later date. It should only be carried out in the tertiary care center with ready recourse to blood and operating room facilities. If the patient's condition stabilizes, she can be taken up for expectant management. Complete bed rest is advocated with bedside toilet facilities. Anemia has to be looked for and corrected by blood transfusion if necessary, as there is always the possibility of further hemorrhage. Iron, vitamins, and calcium should be continued. Antenatal steroids can be given to promote lung maturity between 24 and 35 weeks of gestation. If the woman is Rh negative, anti D should be given. Cross matched blood should always be kept ready. Prerequisite for expectant management. Maternal and fetal conditions good. Gestational age less than 37 weeks. Patient not in labor. Fully equipped maternity hospital with facilities for emergency cesarean and blood transfusion. When to terminate expectant management? Completed 37 week of gestation, onset of active labor, fetal is dead, profuse bleeding at any time, maternal or fetal jeopardy. Candidates for expectant management should be hemodynamically stable and less than 36 weeks of gestation. Caesarean section. A caesarean section is done in most cases of placenta previa. As mentioned above, in all cases where ultrasound shows the placenta to be within 1 centimeter of the internal os, it would be better to opt for caesarean section. Caesarean section is usually performed at 38 weeks of gestation or earlier if the need arises. In cases where an adherent placenta is suspected, caesarean section may be planned earlier at around 36 to 37 week of gestation. Problem during caesarean section. Caesarean section for placenta previa should always be performed by an experienced obstetrician and plenty of cross-matched blood should be ready. The anesthetist should also be experienced in all cases of previous caesarean section with an anterior placenta, placenta accreta or percreta should be anticipated and precautions taken. Consent for hysterectomy should be taken beforehand. Usually, a low transverse incision is possible, but sometimes, as in cases of suspected placenta percreta and malpresentation, a classical caesarean may become necessary to avoid injury to the bladder. In such cases, a multidisciplinary approach is essential. Delivery of the baby. The main problem is difficulty in delivering the baby when placenta is anterior. In such cases, the hand is inserted under the placental edge when it will be seen that the membrane will bulge through. However, sometimes there may be no option but to cut through the placenta. In case of transverse lie, also there may be difficulty. Postpartum hemorrhage. The other major problem is uncontrollable postpartum hemorrhage due to poor contractility of the lower uterine segment. In addition, there may be engorged vessel in the lower segment, especially in the anterior placenta previa. Figure of 8 suture or purse string suture over the placental site may promote hemostasis. Bilateral uterine and ovarian artery ligation may be helpful. In some cases, internal iliac artery ligation may become necessary to control the bleeding. Packing of lower segment with the end of the pack brought out vaginally and removed 12 to 24 hours later has also been successfully tried. Radiological uterine artery embolization is effective in a stable patient provided that there is a good interventional radiology department. If conservative method is failed and bleeding continues, a hysterectomy may be needed. Once again, packing of lower segment with the end of the pack brought out vaginally and removed 12 to 24 hours later. Has also been successfully tried. Radiological uterine artery embolization is effective in a stable patient provided there is a good interventional radiology department. If conservative method fails, the bleeding continues and hysterectomy may be needed. In placenta previa, the bleeding is from the cervix, and so a subtotal hysterectomy may not suffice to control the bleeding. A total hysterectomy will have to be performed. Adherent placenta, as mentioned above, in women with prior cesarean section, there is an increased incidence of placenta accreta and percreta, and in such cases, hysterectomy may be the only solution and should be carried out immediately if needed. This option should have been discussed beforehand with the patient. CS in placenta previa should be carried out by a skilled obstetrician and with plenty of cross-matched blood should be available in multidisciplinary approach is vital. Vaginal examination. Vaginal examination and vaginal delivery. Generally, vaginal examination is avoided in placenta previa when there is a minor degree of anterior placenta previa and the head is flexed. Vaginal examination in the operation theatre and the induction at 38 weeks can be considered in the hope of achieving vaginal delivery. This is usually performed only in those patients who do not have bleeding and ultrasound show the placental is to be between 1 and 2 centimeter from the internal os, and another indication is when ultrasound is not available and the diagnosis cannot be established with certainty. If a vaginal examination is done, it should be performed only when a decision has been taken for termination. There should be a double setup in the operation theatre. That is, all facilities should be ready for cesarean section. During vaginal examination, the finger should first palpate the fornices. Only if there is no boggy feeling and head can be felt easily through all the fornices. So the finger be introduced into the cervix and a proper vaginal examination performed. But if the placenta is felt, caesarean section is always better. However, if the cervix is dilated and the placenta cannot be felt, caesarean section is always better. However, if the cervix is dilated and placenta cannot be felt, the membranes can be ruptured and the patient allowed to have a vaginal delivery, provided there is no bleeding. Asymptomatic placenta previa. If the earlier scan showed a placenta completely over the internal os, it is most likely to persist in the later scan. If the 18 to 20 weeks scan reveal a low-lying placenta or a marginal or partial placenta previa, it is best repeated at 28 and 32 weeks, as in many cases placental margination would have occurred. It would be preferable to admit patient with asymptomatic major degrees of placenta previa from 32 weeks of gestation. Those with marginal placenta previa can be managed on an outpatient basis but should be warned to avoid sexual intercourse and travel. Restriction of routine activity is not essential unless placenta previa persists beyond 20 weeks, 28 weeks and becomes clinically apparent before that. Termination is advisable at 37 completed weeks.